In today's module, we're discussing opioid use disorder and medication-assisted treatment. The objectives of today's presentation include becoming familiarized with opioid medications and illicit opiates, understanding opioid use disorder, exploring evidence-based treatment recommendations for OUD, and understanding medication-assisted treatment and its role in treating OUD. So to understand OUD at all, you first have to understand what an opioid is. Opioids are essentially a class of controlled medications or drugs, which include synthetics such as fentanyl, which means they're man-made, used for anesthesia or for severe cancer pain towards end of life. Prescription or legal opioids, which include hydrocodone, codeine, oxycodone, morphine, etc., and illicit or illegal opioids such as heroin. They're intended for use in their treatment of severe acute or surgical pain. They're supposed to be given for short term at the least effective dose, and they're not intended for treatment of chronic non-cancer pain. They may be used to treat longer term chronic widespread cancer pain, but again at the least effective dose. That allows you room to move up when your body develops tolerance. Opioids, by definition, are any substance that binds to an opioid receptor in the brain and produces an agonist effect, meaning it increases the effect or has a full effect of an opioid on the receptor. They're derived from poppies. They cause CNS depression, sleep, stupor, pleasure, and of course you might also remember that they cause respiratory depression, which is often what causes a death in an overdose. They possess strong reinforcing properties which quickly trigger addiction, and tolerance and physical dependence can develop very rapidly. And then once you develop tolerance, which means you need more of the drug in order to achieve the same effect, you have to increase the dose by 100% to achieve the desired effects, which makes sense for patients coming in taking, let's say, 30 Percocets a day. For those of us who do not take that many per day, it seems completely out of the range of anything that would be, appropriate. But at the same time, if you have to increase by 100% of your dose to achieve the desired effect, you can see how that quickly can add up to 30 pills of something. So statistically speaking, opioid overdose is the #1 cause of preventable death in the U.S. Since 1999, the sale of prescription opioids and the number of opioid overdose deaths has quadrupled. In other words, 4 times as many deaths since 1999 and 4 times as many sales of opioids. There's an increased use of black market fentanyl and heroin because they're cheaper and easier to acquire. So if you have a patient who goes to a pain clinic, gets addicted or completely dependent on opioid medications there, or maybe they doctor shopped and they've gotten addicted to all kind of medications, and then all of a sudden they don't have access to their narcotics anymore, their opioids anymore from their physician, so they may choose to go towards illicit opioids because they're cheaper, easier to acquire, and you can achieve some say an increased effect compared to prescription opioids. Over 2.5 million Americans are dependent or misuse their prescriptions. Over 1,000 people report to the ER every day misusing their opioids. 78 people die each day from opioid-related deaths. And probably the most staggering statistic, one that really kind of catches your attention, our country, the United States, comprises 5% of the global population, but we consume 80% of the world's opioids. So what is opioid use disorder, or OUD? Essentially, it's a problematic pattern of opioid use which leads to clinically significant impairment or stress. So how do you determine what's clinically significant impairment or stress? The DSM-5 has criteria that you can see here. I've listed them here. I'm not going to read them out to you. But if you possess at least 2 of these within the last 12 months, then you have opioid use disorder. So that could include things like great deal of time obtaining your opioids, craving or strong desire to use, recurrent use even in hazardous situations. So even though I passed out last time, I'm going to use it again, or maybe I go, to a deep alley to obtain my opioids. That's part of what is going to diagnose someone with opioid use disorder. So as you can see there, tolerance and withdrawal are also included, and those can be developed in a matter of a week. So it's just something to see how it really can vastly affect everyone who uses opioids at all. So here's the severity scale according to the DSM-5. Mild opioid use disorder is 2 to 3 of those criterion that we saw earlier. Moderate is 4 to 5 criteria, and severe 6 or more criteria. So if you work in addiction treatment, then you know that these are common things that we see among our patients every day. So you can see how moderate or severe diagnosis can easily be given to someone. So OUD is one of the most, if not the most, difficult substance use disorder to treat. Opioids are extremely addictive. It's quick to develop tolerance, some a matter of 7 to 9 days if taken at the same amount every day. It has the highest recidivism of all substance use disorders, meaning the highest rate of relapse, and it has the lowest rate of recovery. So frequent relapses, regardless of recovery time, occur strictly because there are latent cravings and withdrawal symptoms that can occur months to years after a patient is abstinent because of the changes that are made in the brain when patients actively use and abuse opioids. If left untreated, most people suffering from OUD will succumb to overdose that can potentially be fatal. So what's the method of action for an opioid? So it enters the brain, it converts to morphine, it attaches to the receptors that stimulate dopamine release, and it results in an intense, pleasurable rush. So on a side note here, they are working on an opioid vaccine, which would prevent the intense, pleasurable rush with the administration of an opioid, which would hopefully decrease the number of people that would become addicted from opioids given for pain reasons. But so these are the way that opioids work when they enter your brain. Converts it to morphine, attaches to the receptors, and then you get the rush or the high. It also results in flushing to the skin, heavy feeling to the extremities, drowsiness, clouded mental functioning, bradycardia, and respiratory depression. So tolerance is when the brain makes adjustments to function normally when the drug is present and abnormally when the drug is not. So probably an easy example of this would be you are driving and you've got your brakes on. You have to push the gas pedal harder to get up to speed. That's sort of the same thing that happens when your brain has adjusted to functioning with the drug in its system, and when you take that away, then it is not functioning normally. Withdrawal is when you no longer have enough drug in your body to which causes you to experience symptoms. So when you no longer have enough of the drug in your system, your body has symptoms that lets you know that you need the drug. That's part of the tolerance. It functions abnormally when it's not present. These symptoms will not go away until you put more of the drug in your body or until your body learns to function normally without it. And that's usually why so many people relapse. That time that they're meant to spend away from the substance, from the opioid, they can't do it on their own. So they can't do it with abstinence alone, and they end up relapsing again. Tolerance and withdrawal is what basically gives us dependence. And so if we're going to talk about dependence versus addiction, dependence is your physical dependence is when your body experiences the withdrawal symptoms without the drug. And like I said, can occur 7 to 9 days after consecutive use. And addiction is more the behavior and the obsession with obtaining and using the drug despite your consequences. So your physical dependence is your body's reaction. Your addiction is your mind's reaction. And here's the neurobiology of OUD. So, and this will explain somewhat of why it's such a difficult disorder to treat. So it causes neurochemical and molecular changes that profoundly alters your brain structure and composition. It enlarges your ventricular spaces. You have loss of frontal volume. And of course, remember that this sort of affects a lot of pathways and circulatory issues in your brain. Produces profound degrees of tolerance and physical dependence. It is powerful motivating factors for compulsive use and abuse, which is unlike a lot of other substances of abuse. And obtaining and using the drug becomes the primary focus in life. So once you start consecutively using opiates, then it literally rewires your brain, and your brain focuses intently on how you can continue that feeling, and how it sort of tells your brain tells itself that you have to have these substances in order to function normally. And the memory of using the substances becomes greater than the memory of anything else. So that's why it's so easy for some people to, and I say easy, they're more motivated to use the drug than they are not to, because the memory of them using it is more powerful than the memory of them not using it. So this is sort of what the brain looks like, and these are some of the areas that opioid use disorder affects, and we're going to talk about that a little bit. So the ventral tegmental area, or the VTA, is one of the most primitive parts of the brain, meaning when a lot of your other systems and organs fail, the VTA will be one of the last ones to fail because it's very primitive. It's a structure in the midbrain that distributes dopaminergic neurons, and not to get so wordy, but essentially it puts out the dopamine to the nucleus accumbens and several other places. The nucleus accumbens is part of the forebrain. It receives dopaminergic projections from the VTA, which we talked about. It's central or important for motivational states and addictive behavior. The principal region in the brain associated with reward, joy, pleasure, and gratification, meaning it's affected by this use, and it's going to really make you it's going to require you to keep feeding it the substance because of the reward associated with the use. It's key element for reinforcing actions of drug abuse and in neuroadaptational changes associated with addiction and drug-seeking behaviors. And the two essential neurotransmitters associated with nucleus accumbens are dopamine, which is pleasure, promoting desire, and serotonin, which is satiety and inhibition. So essentially with opioids, you have an increase in dopamine, a decrease in serotonin. So that means that your dopamine levels are high, your serotonin levels, which tell you, I'm satiated and it provides inhibition, are low. So you're constantly seeking more. And that's part of what happens in the nucleus accumbens. It rewires your brain to focus on obtaining it because you need it to function. So let's talk about the reward circuit. So the pleasure or reward bundle, also known as the medial forebrain bundle, or the MFB, includes the prefrontal cortex, which receives the stimulus indicating the reward. So I've taken my opiate, and so now my PFC is aware of it. It sends a signal announcing the reward to the VTA, which then increases activity and causes dopamine to be released to multiple areas, which then activates motor functions, focusing the individual's attention. So I've taken it, my signal is released and received, and now my brain tells me, great, let's do more of this. And it sort of just is an ongoing battle in your brain. I get my signal, I send it to everyone else, my dopamine increases, my brain says more. I get my signal, send it to everyone else, my dopamine increases, my brain says more. And that's the constant battle going on in the addict's brain. Activation of the medial forebrain bundle leads to the repetition of the gratifying action and strengthens the pathways in the brain. So this becomes a road that the brain constantly wants you to travel. So your brain is literally telling you, I need you to do this again and again and again. And that's part of that repetition, gratification, all that pathway is unlike with opioids is very different in this aspect compared to others because of the dopamine involved. So in other words, your reward circuit and other substances is not going to be as significant as with the opiates because of the dopamine that's involved. So reward circuit, in addition to punishment circuit, is responsible for supplying motivation and behavioral patterns. And then opioids specifically act on the reward circuit more than any other substance because they're acting on the structures that naturally are modulated by endorphins. That influences the dopamine release, which reinforces the memory and strengthens the pathway. So again, this really all goes back to dopamine. If you think back to alcohol, it affects the GABA, which is also very addictive and all of that. But the difference with the dopamine is that it literally rewires your brain, and your brain can do nothing but focus on obtaining the drug because of the memory the dopamine creates and strengthens the pathway in the brain. So it is literally rewiring your brain to require opioids. So it's doubly reinforced because the brain has a natural avoidance of pain. And we all know with opioid withdrawal, patients often complain of pain, including like muscle aches and pains, different, they are heightened sense of pain because you have the rebound pain. Your body's not used to really feeling pain, so now any pain feels like a 10. We've all heard patients complain with an extremely high pain level when they clearly don't appear to be, at least not objectively in that much pain. And it's all because of the rebound pain that they're experiencing because they're coming off the opioids and they have the hyperalgesia because of that. So because your brain naturally avoids pain, which reinforces the need for opioids, and your brain has been rewired to focus on obtaining and using opioids, you have a double reinforcement for use. So some of the things that we've noticed have been the problem with our current opiate epidemic is the concept of pain being what the patient says it is. Again, while there is some truth to this, in other words, I experience pain differently than you and then the next person and the next person, that is true. It's really taken on a life of its own, I think, beyond the intention of the original concept. So in 1990s, there was a push to better manage pain and allow easier access to opioids, aggressive marketing from pharmaceutical companies. There was a push for pain as the fifth vital sign. Of course, most places you have to assess pain when you assess all the other vital signs. And now there's the HCAP scores, which sort of strongly influence your reimbursement for some hospitals and facilities. So there's just so many things going on with pain being what the patient says it is, right? So really, as healthcare professionals, we should take on pain in several ways. We should really tackle it in several ways. First, you have the subjective report from the patient, but then you should also include your objective findings as a healthcare professional and as one that's utilizing your judgment to treat the patient. Some other issues with problems with opioid prescribing includes physician prescribing practices. So a lot of times they would overprescribe because there was this push for you should give everyone pain medicine because they're not going to get addicted. This is not something that's addictive. It's used for pain. So there was that push for that, and then that created an overprescribing and continued overprescribing based on patient complaints. So my med's not working anymore. Of course it's not because of tolerance and withdrawal. And now we have to give them more. And that just created this use culture of excess where everyone needs more and needs a pill for everything. The medical culture has only recently been able to change their perspective on prescribing practices, and the CDC released new guidelines for opioid prescribing. Of course, people are known to doctor shop, go here to get one pill, there to get another. And 91% of individuals who survived an opioid overdose received an additional prescription for opioids from the original prescriber. So part of this could be maybe they didn't know there was an overdose, maybe some of it, I'm sure, too, was really focused on, I'm still in pain, I need this. So there's always that, the patient's perspective. And then poor communication between the pharmacy and prescriber, which now we know that that's improved with use of the PDMP. So addiction is a chronic, progressive, relapsing, remitting disease. The highest recidivism, lowest recovery rates. And I want you to think of it like diabetes, CHF, or any other long-term medical diagnosis. There is no cure, but it can be controlled with the proper treatment. Most individuals will require multiple treatment episodes before recovery is achieved. The same can be said for diabetes and CHF. There are patients that often go through diabetes exacerbations and CHF exacerbations, COPD exacerbations, and have to be rehospitalized for treatment. It's the same concept with addiction. The difference is, while most people don't have negative stigma associated with treatment for diabetes or CHF, they do with addiction. So a lot of it is more of a public opinion issue, and so it's really on us as healthcare professionals to help change the mind and of the public opinion, around that, to try to help educate the public that this really is a disease process and not just a moral failing. So there are some exceptions to individuals requiring multiple treatments. Healthcare professionals spend a longer time in treatment. They have more ongoing long-term monitoring, and they have greater consequences if they relapse. So often they are more motivated to achieve recovery and continue with it. The average person doesn't have random drug screening that they have to call for every single day. The average person may not have, a high-paying job that, requires licensure, and obtaining the licensure is a lot of work. And so they're invested in their work. That's not for the average, person. So healthcare professionals having this requirement to stay in treatment longer because their board requires it and the treatment team recommended it based on their use. The long-term ongoing monitoring, and most healthcare professionals are monitored for 5 years or more. Each state is a little different, but they have ongoing monitoring that the average person doesn't have. And like I said, there's greater consequences and risk for loss for healthcare professionals than the average person. So how are we going to combat the opioid epidemic? There's new prescribing recommendations, of course, like I said, the CDC guidelines, insurance coverage limitations. So the insurance may say, we will only pay for this number of pills. So they want to allow you to, they're going to require you to pay for more than that if your doctor even writes you more than that. And then individual pharmacy implementations. An example of this is my mom had surgery, actually, and the doctor wrote her a prescription for tramadol. And I think it was maybe like 10 tablets or something. It seemed, to be a small dose for a short period of time, but for whatever it was 5 more pills than Walmart was willing to fill at one time. So we actually had to go to like a CVS to get it filled because Walmart would not fill that number of pills, no matter what the laws are, no matter what the insurance said, no matter, that was Walmart's own individual restriction. So you have that at some other pharmacies too. They're implementing their own restrictions so that there's not too many at once. There's also new legislation expanding treatment access. Pharmacy take-back programs where if you don't utilize all of the medications that the doctor prescribed you, you can take it back to your pharmacy and they will destroy it for you. And expanded prescriber education. A lot of places require additional training on opioid prescribing to work at their facility. So we're talking about evidence-based treatments of opioid use disorder. Primarily, we're going to focus on medication-assisted treatment because at this time that is the gold standard for treating opioid use disorder. So MAT is essentially just utilizing opioid agonist or antagonist medications to combat withdrawal symptoms and cravings for opioids. There are 3 approved forms of MAT, which include methadone. Methadone's been around for decades. It's proven effective and is the treatment of choice for pregnancy. Buprenorphine is still fairly new, coming off in the last 10 to 15 years or more. And you can see it in Suboxone or Subutex, and there's several other versions of that. And then extended release naltrexone or Vivitrol, which is an injection. And some also utilize oral naltrexone or Revia. So the World Health Organization considers methadone and buprenorphine essential medications in the treatment of OUD. The issue is that a lot of other prescribers are less likely to utilize methadone or buprenorphine, either because of prescribing or just the stigma associated with that. So it's really important to also be aware the importance of these medications and what their role is in treating OUD, which is what we're talking about right now. So the benefits of MAT, I think, are real significant. It decreases opioid use, opioid-related deaths and overdoses, criminal activity, and infectious disease transmission. So if I'm on MAT, no matter what form, if I'm on that, I'm less likely to utilize or to use or abuse opioids. I'm less likely to overdose and die. I'm less likely to participate in criminal activity, and there's a decreased risk in infectious disease transmission. So one of the things I thought that was really interesting is when buprenorphine came on the market, overdose deaths decreased by 37%. That's a huge, huge accomplishment. considering, where we're at with the quadrupling of the overdoses. MAT reduces opioid cravings and withdrawal, which is a lot of the reason why people can't succeed with abstinence. So yes, there are going to be those that do succeed with abstinence. The amount of people that succeed with abstinence compared to the amount of people addicted to opioids is very minute. So the majority of your people that are going to be successful with abstinence is going to be your healthcare professionals. And we already talked about why that is. It's because, number one, most boards are not going to allow them to be on MAT because because of the job that they have. Additionally, they have more time in treatment, they have more accountability, they have more monitoring. So there's just so many more things that healthcare professionals have that the average person does not have. And so when you're talking about, what's going to work for the majority of people, abstinence is not it, unfortunately. However, there can be a goal to reach abstinence with MAT. And that's sort of what people aren't realizing. They're just thinking you're trading one drug for another. So the fact that MAT reduces your craving and withdrawal means they're less likely to relapse. And we all know the first 12 months of treatment is really where most people are going to relapse, possibly multiple times. So if just considering, getting patients access to MAT in that first 12 months, if we can do that, then we're getting their brain on the road to healing. We're increasing their time in treatment. And that's really what MAT is about. So it's about getting them away from the improper use and abuse of opioids. So it reduces opioid cravings and withdrawal, increases social functioning. So they're able to go and be a part of their family's lives. They're able to work. They're able to, do things that they haven't been capable of doing. They've sort of been isolating themselves and using, or maybe hanging out with the wrong people. So this allows them to have more of a normal functioning life. It increases time in treatment. Probably the biggest benefit of MAT is that it increases the time in treatment. Not a lot of people get, an extended amount of time in treatment. 30, 60, 90, 120 days is often out of the range of normal for a lot of people. So if they go through detox and they finish their program and then they're transferred to medication-assisted treatment, then that is increasing their time in treatment. They're still getting treatment because with MAT, you have to have a clinical aspect. You have to have counseling in order for it to be to work. So you can't just take meds and it work. You can't just do counseling and it work. You really need both of them together, and that's why it's called medication-assisted treatment. So it increases their time in treatment. It restores the balance to the brain circuits, which were affected by addiction, which we just talked about, allowing the patient's brain to heal while working toward recovery. So they're taking this medicine, they're not getting high because it doesn't cause a euphoric feeling. Of course, there's a transition period where it takes their body a little time to adjust, as with any medication, but there's no euphoria. They're actually just allowing their brain to heal while they're not experiencing the craving and the withdrawal. Because the craving and the withdrawal are what's going to, make them obsessed over using, and they eventually relapse. So the point of MAT is to reduce the cravings and withdrawal, increase the time in treatment, allow their brain to heal, which gets them on the road to recovery. Now, you can talk about tapering off of MAT later. Honestly, it's not recommended within the first 12 months. So it reduces the symptoms of NAS as well, and the length of hospital stay for pregnant mothers and newborns. Methadone is a full opioid agonist. It's the treatment of choice in pregnancy. It's appropriate for patients who have a severe use history, multiple relapses, if they're less motivated to be abstinent, if they have severe cravings, poor accountability with self-administration of meds. So methadone requires you go to a daily dosing clinic. It's not one that you can get a prescription and go get filled and go home. Like, it requires you coming to the daily dosing clinic. It's titrated up over weeks to maybe even months for some patients to the least effective dose. So the goal is that, and because, it has a half-life of around 50 to 30 hours, so you don't want to just increase the dose like on a daily basis. You want to increase it very, very slowly over weeks to months so that you don't build it up and then have this huge crash. So it's why it's titrated very slowly. But the point of titrating it up is so that you get the dose that decreases the cravings and the withdrawal symptoms, but doesn't cause the euphoria or oversedation feeling. So that's kind of what you're going for, and it takes a little time to get to the right dose. It can be fatal if it's overdosed, and it should never be given with benzodiazepines because of the risk of overdose deaths. And like I said, you have to include your clinical therapy in order for it to be effective. Buprenorphine is a partial agonist, meaning that while methadone is a full agonist, it fully fits into the mu receptor just as an opioid would. Buprenorphine is a partial agonist. It doesn't fit exactly completely in the opioid receptor, but it partially fits. It can come in combination therapy, which is buprenorphine with naloxone. The naloxone is there strictly to prevent diversion and shooting up of the med. The monotherapy is buprenorphine by itself. This is recommended, monotherapy is recommended for pregnant females if they're choosing to not utilize methadone. So methadone really is the treatment of choice because it assures, or they're less likely, the mother is less likely to relapse on illicit opioids if they're taking methadone. If the patient, the mother is really motivated for treatment and they want to do buprenorphine because, there's some studies that suggest that the neonatal abstinence syndrome is less harsh with buprenorphine than methadone. So some mothers may want to do that. The problem with buprenorphine in pregnancy is that studies do show that mothers relapse more often on buprenorphine than they do when they're on methadone. So it's important that that discussion be had with the patient, that they're highly motivated to achieve recovery, that they understand that they're, they could relapse while on buprenorphine more likely than while on methadone, and that they can make that informed decision. It's available by prescription. So in other words, I can get a prescription from a DEA waivered licensed prescriber and go get it filled at a pharmacy and take it home and take it myself every day. It's available in daily dosing clinics as well for those patients who have poor self-administration practices. So in other words, if I have proven that I can't be trusted to administer my med daily appropriately, or maybe I've been selling my Suboxone strips for or trading them for other substances, then that type of patient would either be more appropriate for methadone or more appropriate for the daily dosing clinic administration. It comes in multiple formulations, including an extended release subcutaneous injection. So that's another option for patients who are not really candidates for self-med administration. They might be more appropriate for the injection because it lasts about 28 days. They can receive it at their prescriber's office, and then they get a continued release of the med throughout their body from the injection for 28 days. MAT is also available with naltrexone. It's a complete opioid antagonist, meaning that it essentially blocks the receptor completely. So it puts a bridge over, a canyon so that nothing can get in there. So it blocks anything from getting in that receptor at all. It comes in oral tablets that's taken on a daily basis, which again, if your patient is not highly motivated and not able to self-administer and have proven ineffective at self-administering, then that's going to be a bad option for them. They really have to be highly motivated and capable of self-med administration. So your healthcare professionals, this might be a great option for them. Extended release IM injection, which is Vivitrol, can be taken every 28 days. Also a good option for those not wanting to pursue methadone or Suboxone, but really need the relapse prevention, and if they are unable to safely self-medicate with their oral tablets every day, the injection is a great option. It helps to quiet the brain and reduce the cravings, just like the other medications. Like I said, the individual must be motivated for recovery. The biggest issue with naltrexone MAT at all is that you have to wait 7 to 10 days after your last opioid consumption before you initiate the therapy. So it's that 7 to 10 days in waiting that most people relapse, which is why it's so hard for them to get on naltrexone, and it makes it a little easier for them to get on the Suboxone or methadone. It's contraindicated in pregnancy. You cannot administer naltrexone or Vivitrol while a patient is pregnant, at least not for relapse prevention therapy. And studies show that naltrexone outcomes are comparable to buprenorphine. However, again, most patients are likely to relapse during that 7 to 10 days of waiting until they can initiate it. So that's something to consider for choosing appropriateness for your patient. So what's the goal of MAT? Really, our goal is to increase the time in treatment away from your last opioid use, and while utilizing it, the brain has time to heal and correct the pathways that have been rerouted by the opioid use. So the longer that your brain goes without those illicit or those euphoric opioids, the more time it has to heal the pathways and rewire itself, essentially, so that it goes, kind of tries to go back or build new pathways back to normal, for lack of a better way of saying it, a way to function without the constant reminder or pushing or, urge to use opiates. So the goal, increase time in treatment, allow your brain to heal. Some considerations. MAT is harm reduction, meaning our goal is to reduce harm in this population, reduce overdose deaths, reduce infectious diseases, reduce, the decreased functioning, that kind of thing. You must participate in clinical therapy in addition to the medication in order for it to be effective. Some individuals may opt to come off of methadone or buprenorphine through a very long extended taper, which can be over months to years. The biggest issue with this and why it has to be taken slowly is because the relapse potential during a decrease in a dose is very high. So you have to develop an extensive tapering and clinical plan prior to the reduction of your MAT dosage if you're using methadone or buprenorphine. So patients that want to come off of this, which is great, that they should, if they're wanting to come off, they should have, I hate to put time frames on it because everyone's individual, but really they should have 12 months of sobriety under their belt, 12 months of recovery. They should have a good recovery plan. They should be working their recovery plan. All of that has to be taken into consideration before you consider stepping down the dose. Otherwise, you're likely ensuring a relapse. You have to be, there's an extremely high risk of relapse and overdose after abruptly stopping MAT with naltrexone. So, naltrexone or IM Vivitrol is given on a monthly basis. So if a patient abruptly stops say they get 4 or 5 Vivitrol injections and then they don't get the 6th one, they're at extremely high risk for relapse in that 6th month. And really it's any month that they stop it. So you really have to have a good plan. Maybe they're coming to the clinic more often to meet with the prescriber. Maybe they're meeting with their sponsor more often. Like, you really have to have a good clinical plan if you're coming off of naltrexone MAT. And most people that are on oral naltrexone that abruptly stop will almost always relapse. So it's very important to have that good clinical plan. Many patients may never be ready to come off of MAT, and that is okay. MAT allows people to live productive, functional lives without the detrimental effects of illicit and prescription opioid use and abuse. So it's really one of those risk versus benefits. So if we know, you don't want to push someone to come off MAT when they're not ready. So if we know that the likelihood of them relapsing and going back to where they were, which is, likely homeless, debt, no family, no job, all those issues, then, and risk for all kinds of medical and other, infectious disease issues, all of those things, then we're not doing them any kind of favor by getting them off of MAT. Because at least with MAT, they can have a functioning life. They can hold a job. They can go to, their social functions. They can be with their family. They can, lead more of a normal life, even though they're taking a medication every day. That is much preferable to, the active addiction. So that's something to think of on the bigger picture, on the grand scheme of things. You really have to look at risk versus benefits when you're talking about patients coming off of MAT. If they're able to hold a job and lead a functioning life on MAT, then that's where they should be. Some of them will never be able to come off of that, and that is okay because it's working for them. Think of insulin for diabetes. Okay, so you have a diabetic patient. Let's go with type 2 because they can potentially get off of their insulin, right? Type 2. So you have an elderly lady who has insulin on a sliding scale. Say she were to update her diet to actually take some active chances or some active measures to increase her exercise and improve her diet, she could potentially, come off of her insulin. But there's also those patients who will never be able to come off of their insulin no matter what they do. So it really depends on, because they know they're going to eat cake or they know they're going to, partake in this food or that food. So, it really depends on each person. Everyone is individualized. What is capable for some is not appropriate for others. So you really have to think about that and individualize treatment for each person. And you really have to educate the families on the benefits of MAT, how they can be supportive of their loved one that's participating in MAT, and why it's not necessarily a bad thing for a patient to be on MAT, because there's always a stigma associated with it. So if you have any questions, you can reach out to me and let me know. And I look forward to seeing all you guys in the coming weeks.